Well, howdy, y'all. Welcome to this Lipid Insights podcast. I'm your host, Dr. Peter Jones. I'm from Houston, Texas, and I'm here to give you some good relief from having to listen to my friend and colleague, Alan Brown, do most of these podcasts. So we'll be delving into several more of these podcasts, focusing on some of the manuscripts of the Journal of Clinical Lipidology we'll be putting out in the coming year. So stay tuned to future podcasts along this way. So today we're actually going to kick off this series of podcasts to discuss a review article that's going to be published soon in the Journal of Clinical Lipidology. The title of it is "The Role of Nutrition-Related Clinical Trials in Informing Dietary Recommendations for Health and Treatment of Disease." And I'm very fortunate and pleased to have the two first authors of this manuscript with us today as we discuss what this article is all about. First is Dr. Penny Kris-Etherton, and the other author is Dr. Christina Petersen. So welcome, guys, and please, starting with Penny, introduce yourself.
Well, thank you, Peter. I'm just delighted to be here today. I am a cardiovascular nutritionist. I've been on the faculty at Penn State for many, many years. Currently, I'm professor of nutrition emeritus. And I've spent my whole career being interested in cardiovascular nutrition, and in particular, doing clinical trials, looking at effects of different diets, food, bioactives on risk factors for cardiovascular disease.
And I'm Christina Petersen. I'm an associate professor at Penn State, and I actually trained with Penny, so I spent a few years in her lab as a postdoc. And most of my work focuses on nutrition-related clinical trials. So I've done several trials looking at different foods and different dietary patterns as they influence cardiovascular.
Yeah, and I just want to add, too, that Penny, you I think, retired from being a deputy editor of the Journal of Clinical Lipidology. And Christina, you're actually an associate editor for the Journal of Clinical Lipidology. So that's great. Great to have both of you here. Well, with respect to this article, I guess the first question you have to ask is, it's a review article of nutrition-related clinical trials in informing dietary recommendations. So first, why did you and the rest of your co-authors actually come up with the need for this review?
Well, I'd like to just jump in first and say and acknowledge Dr. John Guyton, the previous editor of Journal of Clinical Lipidology. And I worked closely with him as deputy editor a few years ago. And he is just such a strong supporter of good nutrition practices. And he was the one that recommended this article. He said, I just think people need to hear about all these great nutrition studies that have been done that have really guided recommendations, nutrition recommendations for cardiovascular disease prevention and treatment. And so it was him, his foresight, his vision that actually got this going.
To build on that, really the goal was to promote awareness of, all of these great nutrition-related clinical trials that we have, and that have really meaningfully contributed to the dietary recommendations that we have for cardiovascular disease, as well as some other diseases too. And so, in this paper, we wanted to kind of break down some of the challenges with conducting these types of clinical trials, again, to bring awareness to the differences in nutrition-related clinical trials compared to what people might be more familiar with in terms of drug studies. So in this paper, we really break down some of those challenges and then talk about how clinical trials can be feasibly and ethically designed to address nutrition questions that are important.
Yeah, that's a tall order to go through. And I think you guys did a great job in the review. So, one of the things I wanted to first start out with is that we do have nutrition guidelines that I think the American Heart Association has put out, and you list those in I think in your table 2. What are the nutrition and diet recommendations from the AHA? And they're sort of 2 recommendations with the class of recommendation and the level of quality of evidence. So what are those recommendations, Penny?
So, basically a healthy dietary pattern is recommended. And it's one that emphasizes intakes of vegetables, fruits, legumes, nuts, whole grains, and fish to decrease the risk of atherosclerotic cardiovascular disease. And, there's also other recommendations for specific nutrients, like replacing saturated fat with unsaturated fat. There's a recommendation to also reduce sodium and, follow a DASH-like dietary pattern, rich in fruits and vegetables and whole grains and low-fat dairy. But I think the overarching recommendation is, consume a healthy dietary pattern that meets certain specific nutrient criteria, but also that's food-based so that people can pretty easily understand what the recommendations are.
Yeah, well, maybe Christina, you could elaborate a little bit more on one of out of that table 2, which the recommendations are there from the AHA, but you list at least 10 clinical trials that have been used to contribute to these evidence-based recommendations. So which are the ones that really stand out as the best strength and the best quality of evidence for us so far?
Yeah, so Penny just mentioned the DASH diet, and so the DASH studies are listed in that table. So, really the landmark study that we have for the blood pressure benefits of the DASH diet come from a feeding study that was done in the late 90s, where they compared what we now call the DASH diet to a diet that's high in fruit and vegetables, and then a control average American style diet. And what they showed is substantial blood pressure lowering with that DASH diet compared to the fruit and vegetable rich diet, as well as compared to that control diet. So that's really the basis for the recommendations for the DASH diet. And since that study was done, there have been several studies that have replicated those findings and built on those findings. An example of that would be then the follow-up DASH sodium studies. So that then demonstrated the benefit of a lower sodium DASH style diet for even greater blood pressure reductions. So that summarizes kind of the DASH studies that are in that table. We also have the Predimed study. So that's the landmark randomized control trial that really demonstrated the cardiovascular benefits of a Mediterranean diet. And the Mediterranean diet is another helpful dietary pattern that's pretty widely recommended. That's a kind of highlights of 2 of the key bodies of evidence that we have for the widely recommended healthy dietary diet.
Yeah, and if I could just jump in, when you're talking about the Mediterranean diet, healthy Mediterranean dietary pattern, we have other studies as well that support Predimed. And these include the Lyon Diet Heart Study, which was done before Predimed, and also it's Cardioprev. Both of them showing benefits of a Mediterranean style diet. So here we have, all of the DASH studies showing benefits on blood pressure and, a large body of evidence from Mediterranean dietary studies as well, showing benefits of that dietary pattern, not only on cardiovascular disease risk, but also cardiovascular disease events.
Yeah. Now, one of the things that I do want to bring up before we get into some more parts of your paper, which deals with the difficulties in doing nutritional randomized trials. But one of the things are, we hear so much about individual, micronutrient supplements. Hey, don't worry about your diet. Just add this antioxidant or add this uh, special supplement, and that'll take care of maybe not so great a diet. What do we have any studies about micronutrient supplementation like vitamin E or vitamin C, beta carotene, omega 3s, anything?
Yeah. So in the paper, we talk about, supplement studies with keratins and also vitamin E, and how those supplement studies actually showed adverse effects.
Awesome.
Yeah. And Christina, do you want to follow up on that a little bit?
Yeah, so really those trials were conducted because at the time there was observational evidence suggesting that higher intake of vitamin E as well as some of the carotenoids was associated with lower risk of cardiovascular disease and some other adverse outcomes. But when they did the randomized control trial to confirm causation, those results didn't hold. So we no longer recommend supplements to overcome kind of a poor diet. The overarching recommendation is to try to meet nutrient needs from a healthy dietary pattern. And in some cases, supplements are needed, and that should be done with a healthcare provider. But really, for the average person, they should be trying to meet their nutrient requirements through a healthy diet and healthy foods.
And if I could just jump in, and I think that this kind of leads into the discussion of the complexities of diet design, and that is, choosing beta carotene. And, maybe some epi studies showed that high levels of beta carotene intake were beneficial in terms of cardiovascular disease risk. Maybe some studies showing that higher intake of vitamin E was beneficial. But then when you just isolate that single nutrient, everything falls apart because you can't really say that it's really the beta carotene per se. Maybe it's the carrots and the sweet potatoes and the spinach that people are eating to get the beta carotene that are playing some role. And that's in the context then of a healthy dietary pattern. And also with vitamin E, where does that come from? Well, it comes from seed oils. And maybe it's the polyunsaturated fats and the oils, all that they confer that are, yielding the benefits, not just single vitamin E in those foods.
Yes. You agree with that, Christina?
Too, and I think, that's been a challenge with, epidemiology versus randomized control trials. So, oftentimes randomized control trials won't confirm what we've observed in epi studies. But I think we have to, look at that carefully. And, often we reach the conclusion that it must not be a causal relationship. But often there can be other things going on there. So maybe it's a different question. So, like Penny mentioned, foods contain nutrients, but, oftentimes we need to consider what foods or what the vehicles are for those nutrients. And so, thinking about what our question is, what we're looking at in epi studies, and then how can we ask the same study in a randomized control trial to really confirm if there's a causal effect or not.
Yeah, I think that tends to be the problem. I mean, you mentioned that, the complexity of an intervention and designing a trial, and then, and which dietary intervention should we use? Is it micronutrient or is it a little broadly more based, and so forth? But that's leads to, I think, the big question is, why is it so difficult to obtain a strong causal base of evidence about dietary interventions compared to the way we get that sort of good, strong causal evidence for benefit from pharmacologic therapies?
Yeah. So if I could just jump in here, it's so complicated. And in part because you can't just change one single thing with a nutrition study. With a pharmacological study, participants take either the drug or the placebo. And it's so simple, nothing else changes. But as soon as you start doing nutrition studies, um, the design is so complicated in that, here, for example, let's say you want to look at fruits and vegetables and what their effect is on some endpoint. Well, what fruits and vegetables? They're all so different. And, you can't just look at one. People don't just eat one. But, you know, if you're choosing some that are high in dietary fiber versus low fiber, that's a confounding variable. Different nutrients, um, they're just it's complicated from the standpoint of really not being able to just control one dietary factor. And Christina, there's a whole list of other things too.
Yeah, and I think a key distinction between drug studies and nutrition studies is for a nutrition study, you have to be able to answer the question of relative to what. In a drug study, there are placebos, right? So you're not really concerned about what the control group is doing versus in a nutrition study, the outcome of your study is determined by what that control group is doing. So, being able to answer what the effect of your intervention is relative to whatever the control group is doing. So your intervention group is reducing saturated fat, for example. What is the control group doing? Are they having higher intake of carbohydrate or, some other nutrient? And that's going to influence the strength of your effect, the direction of that effect. And so, ultimately that can, influence the conclusion of that trial, which really doesn't happen in, studies of pharmacological agents.
And with pharmacology, you can get a much bigger, stronger effect. And we see that with both, cholesterol lowering and also, with blood pressure lowering as well as other endpoints too. And so with diet, we have to appreciate that it works through multiple mechanisms and the effects sizes basically are much more modest. And oftentimes studies are done in healthy people. So it takes years and years and years to see major endpoint effects. And for that reason, there just aren't many of those studies at all.
Yeah. I think most of us who aren't nutritionists, but are practitioners and trying to talk to our patients about what they need to do, the big question always comes with adherence. And of course, in these clinical trials, it's the persistent of adherence that tends to be the problem. And I think, as opposed to a pharmacologic trial, you really don't have a specific set of biomarkers that help you assess adherence. So you can't jump in at any time and say, let me check this to make sure they're adherent. So yeah, I think, don't you find that a challenge with the adherence and just a way of not being able to make sure the patient's doing what they're supposed to be doing?
Yeah, absolutely.
It's a key challenge. And, most of the time we rely on participant report and, we all know the limitations associated with that. But often, getting them to fill in some kind of checklist is the best that we can do. So it's a key challenge. And, within our protocols, we create, ways to try to maximize adherence, but, it's a key challenge.
But if we could maximize adherence, that's the key, we would see much bigger effects. And I think there are two perfect examples that speak to this. And one is in the pounds lost study that Frank Sachs and George Bray did, looking at the effects of, different macronutrient weight loss diets on weight loss. What they found is that after 2 years of intervention, the people who adhered the best to the diet had the greatest weight loss. And another example of just how hard compliance is and how it affects the endpoint response is the portfolio diet. And this is a diet that was done by David Jenkins in Canada. And basically, with a controlled feeding study, he could achieve a maximal blood cholesterol lowering effect with a portfolio diet with low in saturated fat, high in viscous fibers, and had some plant protein. That really did mimic that of a first generation statin drug. He saw a 29% reduction in LDL cholesterol. Then, when he implemented this diet with dietitians, with committed participants in a free living setting, he only saw a 13% reduction in LDL cholesterol. Still good, but basically less than half what could be achieved with controlled feeding for just 1 month. So this participant adherence is such an important issue, and it truly does affect the endpoint response as it relates to, as well, the length of the trial. The longer it goes, the more participant burden, the more they're asked to do, the greater the adverse effect on adherence and compliance.
Yeah, that's an important point. Is that there were a few biomarkers that we look at as risk factors for cardiovascular disease, like LDL cholesterol or triglycerides or blood pressure, as you mentioned, Christina, in the DASH diet, weight loss, and so forth. But those are much shorter duration sort of interventions and controlled, and you get these kind of nice effects on those single risk factors. But the problem is, if you choose a outcome that's not just a biomarker, but if you're looking at an actual MACE, looking at cardiovascular events, how do you get that adherence to last 4, 5, 6, 7 years to get that MACE outcome, right?
Yes, and especially in the environment that we live in. It is so food centric, and there are all of these unhealthy foods that people imbibe in really all the time. So it's just really complicated and hard, I think, challenging.
Yeah, it definitely is. It brings up as a practitioner who's had to face these discussions with patients over the years as to what they need to do. I might bring up to you guys as nutritionists, what if a practitioner said to you, "Oh, well, listen, we got pharmacologic therapies that produce atherosclerotic cardiovascular disease, statins, antihypertensives, GLP-1s, SGLT2s. Why do we need diet? I mean, why do we even need to just give the patient the medication, tell them that that's going to reduce their events, and we don't need to worry about diet adherence?" What do you say to that?
What do you say, Christina?
Well, I think it's both and, right? So, the drugs are important, but I think, you can maximize the effects of the drugs by also having, a healthy diet and being physically active, sleeping enough, reducing your stress, all of those things will also improve your health. So I think it's not one or the other. I think it's both. And looking at the goals of the patient too, maybe they do have some goals around improving an aspect of their lifestyle. So you can tap into, that motivation to get them to make some small changes that will, augment the effects of the drugs that they're taking as well.
Yeah. And I am so happy we have these drugs, even the GLP drugs as well. It's so sad that we are at this point in time, but it's a wonderful treatment for a lot of people who just struggle with diet. But I think that having both and I is really important. And I still think that a healthy diet has effects that go beyond just treating certain risk factors. We're seeing this more and more. And even things like, you know, um, effects of diet on other things that affect cardiovascular health. So, for example, we know that people who eat a good diet then can get better sleep, and people who eat a good diet then are more likely to exercise. And so, there are these, additional consequences that go far beyond just blood pressure, LDL cholesterol. So I think the two combined, when patients really need, blood pressure lowering and they need cholesterol lowering, yeah, drugs are okay, but don't throw the baby out with the bathwater and forget about diet. Do both, and they'll benefit you in so many other ways.
Yeah, and I always think about the idea that most of the time when we use these drugs, we're using them sort of later in life in a higher risk patient population. don't you agree that instructing on diet and better eating habits is more of a primordial sort of lifelong risk reducing strategy? That's the way we should be talking to our patients. You should be doing this from the time you're 15 years old, at least, for the rest of your life. And then I don't need to give you these drugs 30
Yeah.
years down the road, right?
Well, my goodness. And I just look at the research coming out showing that the longer an individual has a risk factor like high blood cholesterol levels, the sooner they're going to get cardiovascular disease. We're seeing, the studies showing that children who, have high cholesterol, high blood pressure, high glucose for 15 years or so, starting at the age of 10, have cardiac events, coronary events in their 30s.
Right, right. And we should be talking to them earlier in life to avoid obesity, eat the right foods, exercise, and not have to wait till the end and start realizing, oh my gosh, look what you've got. I need to start using these pharmacologic agents to reduce your risk of cardiovascular disease. Yeah, I mean, it's
And
difficult as it is. It's
yeah,
important.
and surgeries too.
Yeah,
I just look at hip surgeries and knee surgeries and all that are related, to all sorts of things, but some are related to overweight and obesity for long periods of time.
yeah. Do you guys? Here's a sort of provocative question about these dietary changes that we do need to talk to our patients about, even though we have struggles in trying to produce the outcomes we always hope in these clinical trials. But do you think diet favorably affects the gut microbiome to a point that it improves risk for cancer as well as cardiovascular disease, et cetera?
Yeah, I mean, I think we're learning a lot about the microbiome, and I think, we, definitely have a lot of evidence at this point that diet influences the bacteria that are present in the gut. And, we're trying to, do a lot more research to understand kind of the functional implications of that. So, I think the answer is there's definitely strong signals that diet is influencing the gut, and the gut may modulate some of the effects that we're observing for cardiovascular disease, diabetes, and some other diseases too. That's an active area that people are researching.
Yeah, that's great. We've had a great discussion, and in the article you bring up a lot of points about the challenges in getting the kind of information that most of us would want out of nutritional trials. Sort of why doesn't it look like pharmacologic interventional trials? But while you bring up a lot of those questions, you do come up with what you think the future of nutritional research directions should be. So what are those? What is the direction?
Go ahead, Christina, and I'll follow up.
Yeah, so, as we've talked about, we have a lot of evidence about, what a healthy dietary pattern is, what are patterns of eating that are associated with lower risk of disease, and then with confirmation from clinical trials. So, I think something that we need more of is implementation science. So, how do we disseminate these recommendations in ways that enable people to adhere to a healthy dietary pattern for their entire lifespan, so that it reduces the risk of these chronic diseases. I think some of it comes to what we were just discussing related to adherence. So what are behavioral strategies, other kinds of strategies that can help people overcome the key barriers to a healthy dietary pattern, and then how to make those interventions scalable. So they delivered through the healthcare system or through other systems to enable broad reach, and to ensure that underserved populations also benefit from these interventions too. And I think this is a direction that NIH is funding more implementation science, and investigation of programs where recommendations are being disseminated, and the point of evaluation is, really around the effectiveness of reaching populations.
And then I think beyond that, I think implementation science research is so important. How can we get people to make healthy choices? But I also think we really need kind of at least a three-pronged approach. We've got to get more physicians involved. And I think the Food is Medicine initiative is just spot on. And let's get physicians knowledgeable about nutrition and talking to their patients about good nutritional practices. And then beyond that, I would really like to see something bigger and more grandiose done. Maybe, at a policy level in a way that positively incentivizes good behaviors. And so this might be a a pie in the sky approach or a Pollyanna approach. I don't know, but is there any way that let's say food industries and even individuals who are following a healthy diet, who are buying, healthy foods, um, get certain tax breaks or tax credits? And so rather than a punishment approach, is there some way that we could, you know, um, favor people in ways that, seem to work with their pocketbooks and giving them, financial incentives in some way to eat more healthfully. And this could just be very, very, very widespread. It would take, a huge effort, but I think we could get started at a grassroots level. Maybe grocery stores can give discount coupons or discounts for people who buy more fruits and vegetables or some such thing. But I'd really like to see us try and do something along these lines to incentivize good good eating behaviors because, I think, I mean, how on earth do we compete? How on earth does good nutrition compete with, just very, very cheap, inexpensive, unhealthy foods?
Right.
I see these advertisements. You can get burgers now for 50 cents or $1. So let's think about working along the lines of people's pocketbooks and trying to incentivize, good eating behaviors in some way.
Yeah, that would certainly go a long way in trying to help, marginalized and some racial discrepancies that tend to be out there as far as obesity and dietary intakes and all that. So that's fantastic. Well, as we get to the end here, just give you an opportunity to maybe send our listening audience off with some good news and how practitioners might be able to carry that news to their patients about nutritional advice.
So the good news is, first of all, please read our paper and appreciate that good nutrition really does have many, many health benefits. You're going to see studies that come out that show negative findings, but really, collectively, the body of evidence is strong indeed. And a healthy dietary pattern has so many health benefits. So I encourage you not to just dismiss it, but value it and then teach your patients, tell your trainees about good nutrition, the importance of passing the word on.
Yeah, and I agree with that. And, I think something to underscore from the paper is we do highlight the strong body of evidence behind the nutrition recommendations that we have. So, often nutrition is criticized because the evidence may not be as strong as for other fields. But I think, when you look at the totality of the evidence that we have, it is very strong for the key recommendations that we make for our patients.
Yeah, I think that is fantastic. Listen, it has been wonderful to have both of you on the podcast. I want to take a moment again to remind the listening audience that we've been discussing the review article that's soon to be published in the Journal of Clinical Lipidology entitled "The Role of Nutrition-Related Clinical Trials in Informing Dietary Recommendations for Health and Treatment of Disease." And as Penny said, she encourages all of us to read it and then take it forward, and to our patients, to our trainees, to our fellow colleagues on implementing it. It's a great article. I appreciate both of you being on in this discussion. I thank you all very much.
Thank you.